Hello, my name is Lisa DePledge, and I'm a second year medical student at the UW Spokane Foundation site. And this past summer, I did a study investigating the impact of a pre-operative checklist on surgical delays in adult complex spine surgery. To start off with some background on this project, Virginia Mason is a hospital in Seattle, Washington, with a high volume surgery center where patients from all over the country will come for surgical correction of adult spinal deformity. And because these complex spine surgeries are associated with a high risk for adverse events, these patients must undergo medical optimization and they must be cleared by a multidisciplinary spine conference before they may proceed with surgery. And because there's so many moving parts in this process of optimizing patients for surgery, some aspects are sometimes missed, which leads to surgical delays. And not only are these surgical delays associated with worse health outcomes, but they're also expensive for both the patient and the hospital. So in an effort to minimize these surgical delays, Virginia Mason created a pre-operative checklist detailing all necessary aspects of medical optimization and clearance for complex spine surgery for adult spinal deformity. Our hypothesis was that this pre-operative checklist would streamline the pre-operative optimization process and thus decrease surgical delays. The methods that we used in this study to implement the checklist was to recruit a nurse on the team as well as a physician assistant to use the checklist. And they implemented it on September 1st, 2020, and it was used through August 1st, 2021. We compared the number of surgical delays in this cohort with the checklist compared to 2.5 years of a historical control that did not use the checklist in their pre-operative optimization. Surgeries that were delayed due to COVID or those that were that deviated from the established care pathway were also excluded. And where I came into this study was I used the electronic health record to identify surgical delays in patients receiving complex spine surgery for their adult spinal deformity. In addition, I collected data on the need for post-operative intensive care as a proxy for adverse events. Once this data on surgical delays and need for post-operative intensive care was collected, I used the chi-square analysis to interpret the data. So moving on to results, you can see in this top table here that interestingly enough, there was not a significant change in the number of delays in the group using the checklist compared to the historical control. So you can see here in the control group, about 19% of these patients were experienced surgical delays. And in the study group that used the checklist, about 15.7% of patients experienced a surgical delay. And this was surprising to us. However, we did find a statistically significant drop in the number of patients who required post-operative intensive care. So as you can see here in the control group, 25.3% of patients needed to use the ICU after their surgery, compared to 11.1% of patients using the ICU in the cohort that used the checklist to optimize their surgery. When we compared the cause of delays in the historical control versus the study group, we can look at the bar graph right here. That shows us the frequency for each reason of delay in control versus study. So the reasons for surgical delays included perioperative complications, medical unoptimization, patient-directed delays, patient illness or injury, scheduling complications, insurance delay or denial, and conference request for additional information, and then also some delays happen for unknown reasons that I could not find in the EHR. So most interestingly, we can see here that the frequency for delays for all reasons decreased with use of the checklist, with the exception of patients who were medically unoptimized, as well as insurance delays and denials. Which moves me to the discussion section of my poster. It may be reasonable to conclude that the drop in the need for post-operative intensive care may be secondary to the improved medical optimization. This would also make sense that there is a higher number of surgical delays due to the need for additional medical optimization because the checklist was intended to allow patients to proceed with surgery only when they're medically ready. So basically, we are postulating that this checklist might have actually caught more people who are medically unoptimized than they otherwise would have been found. Alternatively, it's also important to point out the fact that the COVID-19 pandemic might have been a confounding factor. While the preoperative workup protocol did not change, it's possible that it may have influenced which patients were selected to proceed with surgery. In conclusion, the checklist directed preoperative optimization did not reduce the number of surgical delays, but it may have the potential to increase patient safety as evidenced by the decreased need for postoperative intensive care. Further research is needed to determine the economic and system impact of delays related to a preoperative optimization protocol weighed against the reduction in adverse events these protocols can provide. Thank you so much for attending my poster presentation, and I hope you have a great day.